in order to appreciate the different angles and the different pressures and all that, you've got to own a sensation of what is loose or easy and what is stiff or anchored and bindy. Okay, so we're going to start that palpation by, you see that you got two pieces of paper towel here with some perforations in it. Okay, so your left hand is going to be your stabilizing hand. Got it? And you pay attention to the sensation in your left hand. So if I move this piece of paper towel back and forth, do I feel any tug on my left hand? Not really, right? There's no real tug on my left hand. So this monitoring hand, or it could be your forearm, is experiencing what it's like if the applications are working at ease. They're not putting any kind of tensile force into the tissue. It's not stressed or strained. But if I now pay attention to your left hand, if I take, is that my left hand?
Yes.
Okay. If I, all of a sudden I didn't know. If I take and start to separate my two hands, just move your right hand. Stop as soon as you feel something in your left hand. Feel it tug in your left hand just a littlest bit. That's bind. That's the end of the range. Now, if we go from ease to bind and just past it, we're going to put a little bit of slide between whatever two layers we're at. Just a little bit. So now I want you to think fluid. We're going to move fluid. Fluid happens with a pump, right? And it has a pressure gradient. It moves downhill typically. But if I want to, and there's a concentration of these little connectors between layers in through here. So if I want there to be room, space, for the fluid to accumulate in there, and then I separate my hands or forearms or a joint movement just enough so I can feel it in my left hand, and then let go and do that again, I'm creating a pump.
Ease to bind, ease to bind.
That is the premise of lymphatic drain. How many of you have heard all this kind of hype around lymphatic drain? And yeah. So you're creating a pump. Now there is a difference between changing your style a little bit, or your approach, or you're modifying a glide or a knead or whatever to address a function that's fairly normal, and you're just trying to mimic normal, as opposed to somebody that is dealing with a pathological condition. Lymphedema, pathological lymphedema, there's some sort of major obstruction somewhere in the flow pattern. And it causes increase in interstitial fluid, and you see an increase in volume of the arm. Anybody seen anybody with a lot of swelling in their arm, for example, or in their leg? It happens lots of times after a surgery, because the normal pathway for that fluid to recycle it has been obstructed, and it doesn't necessarily have a drain point. So that's not what we're doing. The reason why I'm not teaching you to deal with pathological lymphedema is because it is a complex condition where there is a high chance of something called adverse effects. The skin is fragile. It often will split. Not like the whole thing splits open, but there'll be areas where you see little ulcers or something. So the skin integrity is compromised, which means it's a route for infection. The fluid that has accumulated in those cells, and it can also that fluid can get dense like Jell-O. And if it is actually an accumulation of fat along with it, then it's called lipedema. Lipid is a fat. The fluid in there is got a lot of toxicity to it. It's dirty. It's dirty fluid, and so because it can't get into its filtering. Nice job, Luke Allen Fritz. So it can't get into the filtering. So it's collected right there. And there's almost always some underlying cause for the obstruction. Okay, that you can use the methods we're teaching you, but because that is a complex and significant pathology, that should be done along with in an interdisciplinary format with another medical professional, healthcare professional. I wouldn't want you to think that you can deal with a complex lymphedema issue, nor should you. That would be a referral and then some sort of consultation and communication back and forth, because there's such an increase in adverse effects. But just to move lymphatic fluid is just recreating how the body does it on its own. And it does it by walking and bending joints and how the tissues move when we move, and we can mimic, I just threw something on the floor, we can mimic normal on that. And you'll have a specific focus with that. We're just starting to try to create the awareness of that. Just like when layers are sort of stuck together, the lubricating fluid isn't in there very good. And if you just slide it back and forth like that, or around like that, lots of times it'll just loosen up. And the layer will let go. And the hyaluron or the lubricating fluid in there will be able to redistribute. Okay, so back to our ease and bind. My premise then, and then the other, I gotta back up. The other major fluid problem you can get is when there is insufficiency in venous return. And
so now from your heart through your arteries. So your heart pumps blood through your arteries, then the blood has to go in your veins and get back to your core, to your heart and lungs, so the veins.
Yeah, and that's not called edema, which is the fluid that's around the cells. That's a congestion, and it's fluid in the tube. And you'll sometimes see bulging veins when somebody has that. And a lot of times, like in congestive heart failure, you will see both. You'll see edema, plus you'll see congestion. Now, fluid kind of stuck inside a joint capsule, which is like a balloon in there, is called effusion. So where the fluid is at sometimes determines what it's called as well. But it's still a watery fluid with a protein type component to it, which means that it can get thicker or thinner, and it's either delivering nutrient or it's picking nutrient up for it to be, or picking waste up for it to be cleansed and go back. That's the basic premise of it. Okay, back to our ease and bind. If I want to pump fluid, I'm going to go from ease, which allows for room for fluid to accumulate a little bit, to bind. Ease to bind. That's pump. If I want layers to slide back and forth, I'm going to go ease to bind, where I feel it in my left hand and I move in my right hand. All right, now you need to pay attention to those perforations. All right, we want to apply increased, this would be a tension stress. We want to apply increased elongation just until you can see space between those perforations. Did somebody tear their client? No? Good job. And the change is going to happen at the bind right there. If I go too much on that, create too much strain, now I've got, oh dear, now I've got a really big wound, right? Which now is going to have to heal. It's going to have to heal. So do I want to stretch it? Do I want to pull a wound apart? Because the wound's got to come together again. So would this kind of a method be a good thing to do? But I could do this. I could push the areas together. Are you starting to see, once you understand what is being accomplished here, is how you would make your choices on what you're gonna do? So,
even if it's just what direction you apply your glides, right? Just what direction do you do stuff?
And so if I'm gonna do, if I want layers between tissues to slide, somehow or another, like with my left hand, I gotta do something that is gonna hold one layer down and either move it back and forth on the layer underneath, or I gotta hold it down and move the layer underneath. So this is where your pressure depth comes in again. Oh, look, Fritz. This is our lymphatic.
Is a lymphatic vessel, call it.
Yeah, you come demonstrate that.
Well, part 1, 2 also. I drew on the board there. Let me see if I can give you a better visual. So what you have to understand about lymph vessels and veins, not arteries, okay? Arteries have a mechanical pump, your heart, that forces the fluid in one direction, right? So they don't need valves. Your lymph vessels and your veins have structures that are pretty similar. The how they're proliferated in the tissue, there's differences to be sure, but there's these valve systems in either of those tubes, and the valves are oriented in a way that only will open when pressure is from one direction. And if the fluid pressure were to go back up, they're supposed to close and not allow anything to go back the direction it's not supposed to. When those valves break down, it can cause bad issues, and it can be part of the problem. So it should be these valves that open and close, allowing fluid to move only in one direction. And they open and close based on this pump effect of either the skin changing shape, because as I just make my skin a different shape, some of those little valves are going to get opened and some are going to get closed. And if I just keep moving my body, eventually all the valves get open and closed, and it creates a steady pumping point. At the major joints, you have your lymph nodes, which are big concentration sites where there's other, immune system related stuff that will examine and make sure the material coming in, maybe there's a bacteria or an invader if it needs to be attacked. But these nodes which are really highly concentrated at the inguinal, axillary, and here down at the neck. You know, if you ever had like the idea that you have a swollen lymph node here, all that stuff. When there's a lot of extra fluid, those lymph nodes will swell. But anyway, these nodes are also at joints. So you have these balloons, and then with major joint movement at these big joints, like these big ball and socket joints, that also is helping mechanically squeeze like sponges or balloons and pushing that fluid down the chain. The way the body naturally, the mimic normal principle of this is as I move around, I'm doing this. I'm changing the shape of the superficial fascia, which is then, you know, putting pressure on these tubes and the valves inside of them and helping facilitate this pump. And then once they're at the joints, I move my arms and legs at the hips and shoulders. They're at the all major joints. I'm squeezing those. So with venous blood return, same thing. Those veins can run deeper in the body. The valve, there's not a node, but the tube is essentially made of the kind of the same blueprint of these valves. And they rely on not just the shape of change of the skin, but the shape and change of your muscles to create this kind of push on the stuff that causes those valves to open and close as the water is pushed in one particular direction back to the core of the body.
The calf muscles and the is a big venous return blood, arterial blood, and it pushes it. It's just like a bellows kind of a thing. That's what it does. And so people who don't move around enough or don't move their ankles around enough, they're going to get some stasis, or it's going to be still in the area.
And that's the most common place where you're going to see fluid accumulation of either lymph or blood. It's going to be in the lower leg, because that's where we're fighting gravity the most. So the body is having to usually work harder there. Instead of this plexus on the bottoms of your feet, etc. But this blueprint you want to keep in mind is what you're ultimately accomplishing when we're trying to move fluids. So if I can create a shape change here, I'm going to get all the fluid. This is gravity, you know. Initially the fluid has to come out. So new fluid, new oxygenated blood, new lymph comes into the area, right? But then that needs to get out before more can go in. If I just kept on filling that up, the new stuff has nowhere to go. It's just going to flood and turn into a balloon and become congested. So then the body, through movement, is supposed to, I just walk around and I squeeze the bottoms of my feet every time I step on them, and I move my ankle, and that should eventually get this stuff to squeeze up and up out of there into the next compartment. So you have to flip it over. But we get that moved to the next compartment, and here's these little valves that like I have to kind of just change the shape of, and naturally it just happens. Now we're to this, and then I have to do it again. And something deeper in the body is pushing the fluid back down into the tissues, and then it has to come back out to the surface, and then it has to get pushed back up into the core and deeper into the body again. And this fluid pump, this water circulation system is constantly happening. And it's throughout the entire body and all of your tissues. And so this kind of idea of we're just trying to move, if we speak just to lymph, and lymph initially here will be a better analogy, just because when we're moving just the skin, this idea of moving the skin to that bind, to that point of bind, from ease to bind, not through it, just to bind. So from ease to bind, from ease to bind, ease to bind, with the direction predominantly focused toward the heart, towards the torso, is helping facilitate this natural process. A good example of why this can become important: a person becomes less mobile.
If they aren't doing the movements and stuff that would naturally cause this effect, then I, as the therapist, can replicate those movements that they're not doing enough of. And all that is I squish the bottoms of their feet with massage, and I move the ankle around. And that mimics the normal exchange of this. And then I go mechanically to the skin, and I make sure I pay extra attention to moving the skin to this ease and bind, and this ease and bind principle very thoroughly. And the idea being I get this accumulation, and I slowly get it to out of the area, and you end up with a swollen region that becomes less swollen, and you keep moving it. Now, if we have this set up, now let me create the accumulation further down. If the swelling is lower down, so the forearm, the wrist mimicking my ankle, okay? If there's swelling everywhere right now, all right, if this was all full, then what do I need to move out first in order to get this out? I need to move this. So if this was all full, I need to move this first, so that then this has somewhere to go. So that then this has somewhere to go. So you can't start where the balloon is and just move it, because it's just going to hit more balloons. You have to think about this chain of balloons all the way up to the main lymph node exit point. You got to drain this first, the top one first, the one closest to the core. Drain that, and then drain the ones further down. So you start closer to the body, you work further away from the body, but your direction of application is towards the body.
So can you see how we're using analogies like, I'm gonna let you play with this. Well, so that you can see how you're moving stuff through there. And you can't get that to move if you just squeeze it once and wait.
Right.
Yeah,
You
that's
can't
that.
even just like push it.
Yeah.
You have to manipulate it.
So it is much easier to visualize what you're trying to accomplish when all we can see is the skin, the big picture in the skin. It's much easier to visualize that when you've got some sort of model or an analogy or something that can go with it. So each of these things that we've talked about now, which is fluids, moving by our pressure levels, got to get to the layer, and then you go down and then you go out. And then if we want to get to a spot, somebody has a spot. In general, you've got 3 layers of muscle, 1, 2, 3. In general, I'm speaking generally. So in a compartment, in my arm or in my leg or in my back or whatever, I've got 3 layers. The first layer, because now we got all this on top of it now, right? All right, so my pressure has got to penetrate down enough so that it's affecting this tissue down here. So this is going to take more effort to get my pressure down there. So once I get enough pressure so that I can start to affect each of these layers, again, generally, your first layer of muscle is going to cross 2 joints, and its job is to produce the full range of motion. The next, and it's usually called the agonist. And then, or another term you might hear is prime mover. The next layer down is, in general, going to be a helper, but it doesn't cross 2 joints. So my bicep here crosses it across the elbow and across the shoulder. That means that muscle can do this and it can do this. It can do both of those. It doesn't do a very good job doing them both at the same time, but it can do both. Okay, the next layer, usually, we'll concentrate on the elbow, usually is a broader, fatter, flatter type muscle that doesn't cross one of the joints and has a pretty solid attachment right on the bony structure. And it provides the strength. It's called a synergist. It's a helper. Then the third layer of muscle is smaller again and tends to be right around the joints. And it is trying to help with stability. So it's called a fixator. So there's more. There's a neutralizer and all that kind of stuff. So agonist, synergist, fixator. On the opposite side, so this movement is flexion, but this is becoming longer, right? So this whole action here, all of them working together, that brings that closer into the body in a flexion, is called a concentric contraction. It's pulling together. On the opposite side, the group of muscle structures that would create the opposing movement. So if this is elbow flexion, then if I want to get out of that and come back down into elbow extension, all of these muscles need to be allowing an elongation for me to flex, allowing an elongation while maintaining tone. So that's called an eccentric action. And then when I go to straighten my elbow back out, this is now where the concentric action is, and this is where the eccentric action is. So concentric, eccentric, agonist, antagonist, synergist, fixator, those are all related to function. And they change depending on what's happening. Okay, so as a group, I concentrically contract these. Those are the ones that are concentrically contracting. You've got your prime mover, your synergist, your fixator. And then the side that's getting longer is your antagonist. And then when I reverse the action, this now becomes eccentric antagonist, and this becomes concentric agonist. Why? I don't know. There's more language even involved in all of this, too. Okay, so when we are thinking about where the muscle tone itself might get disrupted, where an area is more likely to get too tight, where the inhibitory pressure plus movement might be the choice. That's almost always in the second layer. So pressure that just addresses the surface and doesn't penetrate down to the second layer probably isn't going to get it. What you're going to get between the first layer and the second layer is it's stuck. That's what's mostly going to happen. This layer's got to, because this one is going to work on 2 joints. This one's only going to work on 1. This is going to have a long excursion. It's going to go from this big to this and back. But this synergist down here is only going to go, you know, so This one's not gonna move very much, slide, slide. This one's gonna need to slide, slide a lot on this. But if there is disruption and this layer gets stuck to this layer, then it can't, then the slide is, it's stuck to this layer, so the movement is limited to what this layer can do. So almost always, not always, always, but almost always, when we are thinking about strategies, this first layer, now remember all of this is on top of it. We got to get our superficial fascial layer to slide on this deep tissue and the first layer of muscle. We're trying to translate this first layer on the second layer, like you saw us do with this. That's mostly what we're doing. So our pressure is going to be enough so that we can grab the first layer and stabilize the second layer. If there is a sensation of tautness or tightness or a spot is going to happen in the synergist. And I don't care how good you are, it's really hard to try to actively move this layer on this layer. So we're going to rely more on the pin and stretch idea, or what we fondly call inhibitory pressure plus movement. So the pressure that I use has to penetrate through here without causing damage, get down here and change the shape of this layer without pressing this layer against the bone underneath there. So we're in the middle part of it right here, and we're looking for a denser, bumpier area, but more importantly, we're looking for a spot that is generating the symptom the person is experiencing. And that happens because these spots tend to congregate around what's called a neurovascular bundle. So there's an underlying nerve action in there. So the amount of pressure now, this is where our level 1, level 2, level 3 comes in. All right, so here, I'm not too concerned about compressing or changing the shape of the blue layer. I want to translate it back and forth. But if I'm going to work on a spot, then I've got to get my pressure down enough so where that spot is going to change shape. Now, if I do that with a narrow focus, there's a chance I'm going to damage the tissue on top before I get down through there. But if I do it with a broader focus, this can move away from me. Yep, that can move away.
The spot gets squished.
The spot gets isolated and squished.
As opposed to stacked. Because exactly, more pounds per square inch, you're going to potentially bruise the surface stuff as opposed to.
And then you want to add another signal in there so your pressure is more significant. You've got your bending or your compression happening at your spot, but not so much that this third layer down here is getting pushed against a bone. And then we add the movement. Now I'm seeing some aha, finally. Finally! I'm seeing some facial expression that's going, oh! I get why we're doing things a certain way.
Now, a little bit tied to these visuals would be this idea too, that I have all these layers, okay? And let's say we have the bone, all right? If I want to pull all this off, based on how the body's oriented and whatever I'm trying to work on is oriented, am I gonna come down on it in such a way where I'm impacting that ball directly into the skeleton, the bone? Or do I apply it in such a way where it's sheared off and away from the bone?
Which is
Okay.
better.
Or do I turn the whole body in such a way that when I apply force, it's going to naturally pull things away from the bone? The best example I can think of right now is working on the legs in prone, like the hamstrings and the calves, right? You go to work on those and you're gonna go right into the femur.
Or the tibia.
Okay, you turn a person on their side and you start applying forces, and you're going to always naturally be pushing stuff more away from the underlying bone. So it's not that working on things from multiple, because at times, yeah, that's going to cause a little bit extra pressure between all these and create more of a squash because I'm pushing them into a hard surface. So there's a novelty to doing that to the tissue, but we can't sacrifice probably what's most effective, which is creating this separation. And that's really the most easily mitigated by changing the client's position, not the therapist changing where they're at in the body, reaching too far or having to drop down and all of that. So, that.
All right.